A 45-year-old female with long-standing discomfort in her throat and submandibular swelling attended for a submandibular sialogram. I am showing you the lateral neck control radiograph. Describe the findings.
Let's see. Yes. The lateral plain film radiograph of the neck demonstrates markedly elongated styloid processes projecting downwards bilaterally. The styloid processes extend significantly below the level of the mandible, measuring well over the normal limit of 2.5 centimeters. On close inspection, the calcified styloid processes are segmented, showing a pseudo-articulated pattern. This corresponds to type 2 under the Langlais classification system. The surrounding soft tissues, vertebrae, and visible airway are otherwise normal, with no radio-opaque calculi seen in the submandibular duct region.
What is the diagnosis? And explain the anatomical criteria and clinical mimics.
The diagnosis is Eagle's syndrome, which is defined as symptoms of craniofacial or neck pain caused by an elongated styloid process or calcified stylohyoid ligament. Anatomically, a styloid process is considered elongated when its length exceeds 2.5 to 3 centimeters on imaging. However, elongation is frequently an incidental finding. The diagnosis of Eagle's syndrome requires both radiological elongation and corresponding symptoms. Clinical mimics include glossopharyngeal neuralgia, temporomandibular joint dysfunction, dental pain, chronic tonsillitis, and cervical spondylosis.
Explain the clinical presentations, pathogenesis, and mechanisms of pain in Eagle's syndrome.
The symptoms commonly include dull throat discomfort, dysphagia, odynophagia, foreign body sensation, and facial pain aggravated by turning the neck. The pain is caused by mechanical irritation or compression of adjacent cranial nerves, specifically the glossopharyngeal, vagus, trigeminal, or facial nerves. Additionally, the styloid process can compress the internal or external carotid arteries, leading to carotidemia or transient ischemic symptoms. A history of previous neck surgery or tonsillectomy is a frequent precipitating factor, causing local scar tissue formation that tethers nerves to the calcified ligament. Women in their 4th and 5th decades are most commonly affected.
Describe the radiological evaluation, including the classification of elongated styloid processes.
While plain films or orthopantomograms can demonstrate the elongation, three-dimensional CT is the imaging modality of choice. CT allows precise measurement of the length, medial angulation, and relationship of the styloid process to the carotid sheath structures. The Langlais classification characterizes the process as uninterrupted type 1, pseudo-articulated type 2, or completely segmented type 3. This classification is useful for surgical planning, particularly when planning a transoral or transcervical styloidectomy.
Discuss the management, definitive diagnostic maneuvers, and how you would manage this patient as a radiologist.
Clinically, digital palpation of the tonsillar fossa should reproduce the patient's typical throat pain, confirming the diagnosis. Medical management includes analgesics, non-steroidal anti-inflammatory drugs, and local corticosteroid injections into the tonsillar bed. If medical therapy fails, surgical resection of the elongated styloid process via transoral or transcervical approach is curative. As a radiologist, I would recommend a clinical referral to an ear, nose, and throat specialist, and advise a contrast-enhanced CT of the neck if surgical planning is contemplated.